Hello, and welcome to an overview of the University of Maryland Primary Care Practices SBIRT, Screening, Brief Intervention, and Referral to Treatment. In this module, your goal is to review the components of SBIRT, to describe substance use behavior on a continuum, review how SBIRT is included in your practice, discuss what and why a brief intervention is important, and describe where to document all the activities related to SBIRT. So the rationale for SBIRT in primary care, we know that substance use is common. About 60% of the population consumes alcohol on some level. There is in the midst of a paradigm shift on how substance use is perceived. Certain substances like alcohol and marijuana use are becoming much more normalized, where other substances still have a very negative stigma attached to it. The goal of SBIRT is really to normalize the conversation around substance use. Similar to all the work that we have done about depression and anxiety and really integrating that as part of primary care. The goal is to also integrate alcohol and substance use identification and discussions as part of primary care. The goal again is to identify patterns of alcohol and substance use, not necessarily quote unquote problems. The screening tool specifically is not designed to measure how much a alcohol or substance use consumption is affecting somebody's life, but instead just to quantify use. The provider then educates the patient on their use and perhaps motivates patients who are willing and interested in change to engage in healthier patterns. The overarching goal of the SBIRT workflow, regardless of the healthcare setting, is to meet patients where they are. We understand that not all patients and many patients may not be interested in abstaining from use or reducing their use, but it is important to ensure that they're making an educated decision given the information that's provided. So a little more detail about what SBIRT stands for. Screen is the application of a simple, validated screening tool. And so we'll show the specific example used in the EPIC system today. So screening is just like for other health disorders, depression, colon cancer, other screenings, they help identify the level of risk. Brief interventions, it's health education. And so this isn't a discussion where the provider tells the patient they need to stop drinking, but instead inquires with the patient the rationale for their use, how it might be helpful, what struggles they're associating with their alcohol or their substance use, and then discussing any changes that they may be willing to make. Referrals to treatment are pretty few and far between in primary care. However, if the patient does say, I'm interested in making a change, who can I talk to about that? We make sure that the practices are equipped with the information to make an appropriate referral. So like I mentioned, for alcohol use specifically, it's very common among 60% of the population consumes alcohol at some level. And oftentimes, because it is so socially acceptable and sometimes socially encouraged, there's the habit of minimizing the use, where I've heard from many primary care providers, well, I know my patients who drink. My patients don't drink like that, whatever like that may mean. Patients themselves might say that it's not that bad, they're just having fun. Well, my friends drink more than I do. It helps take the edge off. And again, there is a risk associated with different levels of use. No alcohol use at all has ever been found to be healthy. However, there is a healthy level of alcohol use that shouldn't rise to the point of a concern or would require any type of intervention. However, that bar set, as you'll see, as to where an intervention really is valuable is probably lower than you might expect. So looking at substance use on a continuum, I think really helps view it from less of a problem, not a problem perspective, understanding that all of us fall within this range. Anybody who drinks alcohol falls within this continuum. And so we see in the green more healthy use, so patients who maybe are drinking once a week or less, they're limiting their drinking to maybe 1 or 2 drinks on those occasions, or truly only drink a few times a year or less. That yellow is probably where most of your positive patients, and we'll identify what that means in a second, likely fall. Patients who might be drinking just above the recommended level of alcohol use and might start to encounter some concerns related with alcohol. You probably have a few patients who you could think of off the top of your head who are using at a risky level, who are drinking heavily, maybe daily, and have been drinking for a long time, and very likely have medical or psychological issues related to alcohol use. I apologize, I lost my train of thought. We know that there are medical conditions that are associated with alcohol use or increased alcohol use. They have significantly higher costs associated with care. While a lot of these also include genetic factors, we know that alcohol use can either cause or exacerbate these conditions like lung or heart disease, stroke, cancer, cellulitis, injuries related to accidents, and of course, with IV drug use, HIV or AIDS or hepatitis. So what does the SBIRT process look like at my practice? So all patients 18 and over are screened at all visits. And patients who are there and have not been screened within the last 12 months are those who are identified to be eligible. So regardless of the visit type, if they've not been there in the last 12 months, there should be an alert that populates reminding you to complete the SBIRT screen. Once the MA or the provider completes the initial assessments and that SBIRT screen, the provider, if the patient is positive, delivers and documents that brief intervention about alcohol and substance use. So we'll kind of take it step by step. The SBIRT screening can be found within the mental health screen. We do ask that you sort of pin this or favorite this so that it populates directly on your front screen. You don't have to go searching for it because then it's easy to forget. The screen is called SBIRT. We encourage you not to use the Audit C screen because that only includes alcohol questions. The SBIRT screen includes both the alcohol and the drug use questions. So the Audit C starts with the question, how often do you have a drink containing alcohol? And we really encourage you to ask that exact question each time you open the screen, not to only open it when patients are, that they drink. If a patient doesn't drink, they still need to have the screen open. And please don't ask leading questions like, you don't drink, right? Or I know I've asked before, but you don't consume any alcohol, right? Instead, ask the question exactly as worded, as it is a validated screening tool and loses its validity if it's not asked exactly as worded. So asking the patient, how often do you have a drink containing alcohol? If the answer is anything other than never, then you would continue with questions 2 or 3. How many drinks containing alcohol have you had in a typical day when you're drinking? And how often have you had 6 or more drinks in one occasion? That will auto-generate a score. If the patient is male, a positive screen is a 4 or above. If the patient is female, a positive screen is 3 or above. The drug screening question asks simply within the last 12 months, did you smoke marijuana, use another street drug, or a prescription pain medication other than as prescribed? And for marijuana use, I know this is a common question. Your primary care practices for the time being have decided to include this as a positive screen because while it is legalized and people can buy it without a card now in Maryland, there are still risks associated with it. So very similar to alcohol. It's a legal substance. People of a certain age can purchase it, but there are risks associated with overuse and people can develop dependence on the substance. So we encourage you to ask the question exactly as worded. And if even marijuana use, if a patient's used anything in the last 12 months, to note a yes, and then another question will filter down asking to specify the substance. So for alcohol use, one drink is defined as a 12-ounce beer. So if a patient is drinking a 40 of malt liquor, that is not just a drink. So it's important to clarify when they say they have a drink or two, what does that mean? Malt liquor has a higher alcohol content, and so you'll see that less of that includes a drink, 8 to 9 ounces of malt liquor versus 12 ounces of regular beer. Very often when we make our own drinks at home, right, we're very rarely pouring just 5 ounces of table wine or 1.5 ounces of brandy or another mixed drink that usually contains multiple shots within it. So again, please try to identify exactly what a patient is drinking and accurately record how much they're drinking if you're the MA that's completing this. So the interpretation of risk, again, if a patient is a female, a 0 through 3 is a negative, 0 to 2 is a negative score, and a 3 or above is positive. For males, 4 or above is positive. And that scores of 4, 5, 6, and 7 indicate moderate risk. So not high risk, but still their drinking is at a level where it could increase the risk of damaging health conditions or lead to serious medical or mental health conditions. Of course, an 8 to 12 is considered high risk, where the patient is very likely experiencing some type of medical or psychiatric issues related to their alcohol use and or social problems. For drug use, Any response of a yes about recreational substances or marijuana is considered a positive screen and would indicate a brief intervention. So to recap, a positive score is a 3 or a 4, depending on if they are male or female, on the audit C and or a yes response to the drug use question. So now you have a positive screen. So the MA can navigate to the rooming tab. And for the chief complaint, we encourage you to write in SBIRT. You don't have to write SBIRT positive. You can pull the answers in from the SBIRT flow sheet into a note and use the smart phrase .flow AMB SBIRT if you would like. That will pull the screening tool in. This is one way to help remind the providers that, hey, we completed the screen and it is positive. So to please make sure that you're doing this so that the provider's attention is drawn to it and they know to intervene. One question that I get asked a lot by MAs and staff completing the questions is, will my patients be offended by these questions? And the truth is, from doing 1.5 million screens across the state of Maryland over the last 8 years, it is very rare that patients are offended by these questions. By now, in primary care, patients are used to being asked questions about things like sexual health, self-harm, safety in their house, depression, and anxiety. And so we encourage you to pair the questions about alcohol and substance use with questions of other sensitive natures, like those categories that I just named. Another suggestion is to add a disclaimer before any sensitive question so that the patient doesn't feel singled out. So what I sometimes say is, at all annual appointments, we're asking patients some questions about their behavioral health, or once a year, we're making sure that we're asking patients questions about behavioral health, which includes mental health and substance use. And we want to make sure that we fully understand all of your health needs so we can best help you. Patients have the right to decline, but we do notice when there is the option within the system to decline, that people tend to overuse that. The declination rate is less than 3% on average. And so if the patient does decline, you can please note that in the chart, but it rarely happens where a patient refuses to answer the questions. Also, avoiding some trigger words. And so we notice when people take the liberty to reframe the questions on their own, they may use words that are not recommended, like, do you have any problems with drug or alcohol? Or do you suffer from drug or alcohol abuse, right? Avoiding these leading questions, like you don't drink too much, right? Or using trigger words like abuse or problem will often deter a patient from answering the questions. So you've got a positive screen. What's next? The brief intervention. So this is the provider's responsibility. It's a conversation related to health. So they're looked at as educational opportunities to increase awareness and insight around substance use behavior, and they're a vehicle for behavior change. So this really is aimed at normalizing the conversation, right? Just as we're going to talk to the patient about their other medical issues, about other chronic illnesses, of which substance use disorder is, and understanding that time is of the essence, and these are 15-minute appointments, and the providers spend less than 15 minutes in with the patient. Know that anywhere from usually 3 to 5%, but looking across the state, anywhere from 3 to 10% of patients screen positive. And so it's a small percentage of the population that usually indicate a brief intervention. Some steps for that brief intervention are to raise the subject. And so to say, hey, I was looking over the answers that you provided the MA before. Thank you for your honesty. I noticed that you're drinking alcohol a couple of times a week. Tell me a little bit about that, right? Providing feedback, just so you know, or just in case you're not aware, that intake of alcohol each week could be affecting your glucose, which is why your A1C has been running so high, or could be affecting your blood pressure, which is why maybe that medication isn't working like it should. So to discuss different perspectives also and opportunities for change. So quitting isn't the only option. I often hear from providers, well, I tell my patients to quit drinking and they just don't listen. Well, if you tell anybody to stop doing anything, they're very unlikely to do it, right? Without the rationale behind it and maybe some choice given to them. So that choice should be for the patient to develop a plan with you, right? What does that plan look like? Maybe it's just cutting back. Maybe your patient has 2 to 3 drinks each night or drinks 3 or 4 nights out of the week. Maybe they want to cut back to 1 to 2 drinks a night or only drink Friday and Saturday nights, right? So there's different options available that will be to their benefit and lead to healthy change other than just quitting. If in the rare occasion a patient does say that they're interested, I apologize, I'm skipping ahead, looking where this is documented. So within the SBIRT tab within the SBIRT Smart form, there is a counseling and brief intervention section. And so if the patient is abstinent from alcohol already, they're not drinking, you would just select counseled to continue abstinence. Otherwise, you would note the change that was discussed. Maybe the patient isn't interested in changing. You still had the brief intervention, right? And so you engaged with the client, you counseled to reduce or stop. It doesn't mean that they're interested and willing to do it. You discussed it. So you get credit for that brief intervention. So if the patient is not interested in changing, that doesn't mean that they declined to discuss it, right? You discussed it, they're not interested in changing. And then also what was discussed during the encounter, there are options below where you can select, but you don't have to select any of this. I understand this is a lot of documentation. It is not all required. The only part we encourage you to complete is the counseling and brief intervention portion to select one option that maybe you counseled patient to reduce or eliminate alcohol use, whether or not they were interested. And then later we'll get to the referrals made. So if your patient admits to struggles with alcohol or substance use, and or if they're interested in a referral to a substance use counselor, we don't want to make these referrals to patients who say they're not interested, right? We see that a lot happen as well. You make the referral for substance use evaluation or to a care coordinator if the patient is interested in that. Individuals to be considered for a referral are patients who are saying that they would like to change their behavior, those that have experienced negative consequences as a result of alcohol or substance use through using illicit drugs daily, or they scored an 8 to 12 on the audit C, and they want to participate in treatment. Going down further on that form, at the very bottom, referrals made, you can note that they were referred to social work directly to a treatment program through you. Some type of third-party consult service, or maybe this is a care manager. So the only two portions of the brief intervention section that are required are this: what counseling was provided, if any, and then the referrals made. So in summary, patients are to be screened every 12 months at minimum. The brief interventions are to be documented in the manner outlined, and minimizing a patient's substance use or not talking about their substance use is inappropriate practice. There are mechanisms in place to ensure that patients get appropriate referrals to community-based or University of Maryland-based substance use treatment programs, and there are plenty available in your area. So please make sure that you have access to those resources. Two additional resources that I always recommend if you're unsure where you can refer your patients: the findtreatment.org. That website is a free website that can look up by location, by city, or by zip code any type of mental health, substance use, medications for opiate use disorder like methadone or Suboxone, any type of alcohol or substance use treatment that you are looking for across the US. So again, it's findtreatment.gov. And here's my contact information. If you need any additional information, please feel free to reach out. I work with Mosaic Group, and we are under contract through the Maryland Department of Health, Maryland Primary Care Program. And it's been a pleasure. Have a great day.